we have, this was HIV, we have a pandemic, and in order to be able to tackle this pandemic, save lives, is the investment in institutions, investments in people.
Yeah, because a lot of African countries do not necessarily put in money into these hospitals, into institutions, into the systems, into the training, and you find that the ratios just don't add up.
I think I would say I have found that there's a great commitment, a great willingness to work together. And I find that that's been, from day one, it's the willingness to be able to put one and one together and make it work and invest locally and globally as well has been of great value. I do think that, though, the challenges ahead is that we're not, I mean, COVID-19 is one pandemic, but unfortunately, most people in infectious disease or public health like myself, we certainly believe that there will be other pandemics, but also there'll be other major health threats, like climate, for example. We have a drought in the Horn of Africa now that's jeopardizing the lives of people in the countries in the Horn of Africa. It's the ability, the investments by Africa CDC and others in not only in responding to these emergencies, but in preventing. Number one, preventing. Number two is of course responding, and also very importantly the recovery from these health threats.
Right.
And health threats, in many ways, are not just affect health. I mean, we've learned from COVID that COVID affected health, but it also affected the social fabric in our societies. It affected education and the educational attainment of children in particular. It affected economic stability. So I think Africa CDC and a commitment to being prepared and having the systems in place can secure a future where these kinds of crises are not going to be causing these kinds of effects on communities and societies overall.
All right, Dr. Shongwe, let me just pivot to you really quickly. And I want to talk about HIV/AIDS. This is something that I know. I'm Ugandan, so I know and I've watched the evolution of, from the times when people used to kill themselves because they've heard that they have HIV and they have AIDS, from the days when we only had one test center in the whole of Uganda to cater for millions of people, to times when we can now test. Larry, you're the one who introduced me to this testing kit. And I think, you can basically test really quickly on the go, and rapid tests are in place at the moment. So the question is, there's been an evolution, and I'm interested in hearing from UNAIDS' point of view, how things, when you look back, when you reflect, what has worked, what hasn't worked, what are the challenges, those partnerships that you've been creating. How have you managed those partnerships? It would be interesting to hear that.
Okay, thanks. Hello. Working now, right?
Yeah.
All right, thank you. Good morning, and good morning to our ministers and to our partners and colleagues, everybody in the house. Really good to be here. And I like to be called doctor, but I'm not a doctor. So let me be truthful there. I think the important thing is it's been 40 years, as you said. And I think in the beginning, it was a health response. Everything that we were thinking about was about what can the ministries of health in our countries do. We lost 12 million Africans to HIV in the 90s. And we began to recognize that this was no longer just a health response, and it needs to be expanded. So I think one of the first things that started to happen was the expanding the response to what became then the multi-sectoral response that moved to the National AIDS Councils being created outside of health. And the reason that was important was that our forms of prevention were not just ABC, but it was also about shifting and recognizing who is creating vulnerability across HIV. So in order to prevent, in order to keep people alive, a multi-sectoral partnership at a national level we began to push for that. So that was the first thing. We have the evidence that treatment is available and that we need to find treatment. And so the first thing was to convince governments that we should agitate for treatment everywhere. And so initially it was civil society, then governments who joined in as well, faith organizations, there was so many, big movement. And then they entered the TRIPS agenda. And that's what broke the back, I think, of the hold against treatment. Because the TRIPS agenda began to, with agitation from everywhere.
Could you just unpack TRIPS agenda? What does that mean?
So that was the WTO's etc. That was huge. But what was happening now is that ministries of trade got involved. Ministries of trade, NGOs who were involved in trade, joined in with the Treatment Action Campaign, and colleagues from all over the place really began to push the TRIPS agenda. Let's break down and actually change the patents so that Africans can produce generics, right? And so there was a big Doha agreement in 2003 that eventually allowed for drugs to be manufactured outside of these controlled areas for generic drugs in particular. India started first, they were first, and they, so all of us started pushing to buy drugs from India because it was affordable. And then that shifted and other African countries started to produce. So South Africa, a bit Uganda, Yeah.
And I'm really interested in some of the things that you're saying there, because it seems like there was a concerted effort. Yeah. All hands on deck, government ministries, policymakers, the public. It was important that everybody understood that we needed to push.
And it wasn't a short journey, so it sounds like a quick story, but it was decades of hard work before we could get here.
So how do you leapfrog from...
Kofi Annan got involved.
Kofi Annan,
and I think it's important from an Africa perspective. He was then the UN Secretary General of the UN. But he got involved in advocating for this and held the General Assembly in 2000 focused on AIDS and AIDS drugs. And this is where the Global Fund effectively was founded, was initiated.
Global Funds.
That's right.
For the fight against HIV.
For AIDS, TB, and malaria. Yeah. But it was the first time that we're saying we can't just have bilateral investments in drugs, because then it's controlled based on their pharmaceuticals. But if we have a global fund that's multilateral, then we're beginning to have some influence.
Yeah, and then. So global funds, now money is being raised, but did that situation benefit from the fact that it wasn't just an African problem? I know a lot of the cases were in Africa, but there are also HIV cases across the world.
Of course it did, Of course it did. And the fact that it was TB and malaria as well, it wasn't just us. But obviously Africa was still the largest, potential market, if you want to call it that. So the Global Fund happened. It's still taken a long while because the pharma that's coming through the Global Fund, the ARVs, are still coming from the north. I think we're still, even today, at only about 25% that's coming from the south in terms of the drugs themselves. So we've done better, but we're still not there.
What is holding back? What's the holdback?
I think that at UNAIDS we talk still about the colonization of this world. The pharmaceuticals are still controlling this, and they're not. Big Pharma is
American
still not releasing.
Companies in Europe.
Yeah. So, and African countries, our own, and I think CDC would talk about this because, now there's the Pan-African Manufacturing Alliance that is designed to actually start, coalescing African markets to really manufacture and produce together in unison. And that's beginning.
That's very strong. Let's give them both a round of applause. Very, very interesting. Now let's go to UNICEF and Abu. Important work you're doing around children. Really, really important. And also humanitarian work that you're doing in times of crisis. First of all, where's your money coming from at the moment?
Well, I think we, as UNICEF, we are doing well in terms of fundraising. We have a lot of private donors. We have also governments, foundations. Well. I think we're doing well in terms of fundraising.
That's very rare for someone to say we are doing well.
I think it's not enough to address the issues of children across the world. But I do think that we are trying our best to actually support the countries where we're working in. But money is not the only thing. I think money without leadership is futile. I think, and I think I would like really to salute the African Union, the Commission, and the Africa CDC for the leadership that they have shown in the last couple of years. Because without leadership, you know, your programs.
Okay, so that's an interesting point you're making, and I'd want to unpack it.
Sure.
Because how does that work? You, African Union, CDC, what's that relationship? How are you making it work? You say leadership. What does that mean to me?
I think leadership. I think UNICEF as an organization, as most of the UN agencies, we're here to support countries. We have not our own agenda. The agenda is set by the countries themselves, or it's set by the institution like the African Union. So we are very happy as UNICEF of working behind the scenes in supporting those different institutions, African institutions. And we are very happy that they take the credit because it's their vision where they would like to go. Yes, in some of the countries, in particular in some of the complex emergencies where some of the governments are a little bit fragile, we can come in with some of the solutions. But the ideal settings for development and the ideal settings for humanitarian is that the leadership remains within the countries by the local national institution, and we are supporting them from behind. That's the only way.
Explain that with an example. I'd like to hear a little bit more about the leadership.
Sure.
Because you emphasize its importance. Give me an example of where you've seen leadership.
Absolutely.
How it has worked.
Absolutely. I think I would like to take, Minister Leah is here, and we can take Ethiopia as a very good example. When Ethiopia decided that they would like to put community health workers on payroll and at work, it was a country's decision, even though that the global community was actually against it. So this is how the health extension worker has been basically took place in Ethiopia. Today they have, I want to believe, about over 40,000 health extension workers, which are at community level on government's payroll. And all of us, international institutions, are benefiting from that because we are basically, our programs, health programs within those communities are actually carried by those community health workers, which are actually paid by the national government. So this is leadership. Leadership provided by the government. They have set the tone, and we are buying into it. The same example that we can say in Rwanda. In Rwanda, there's one plan, and countries have to come in. Any institutions will have to buy into this government national plan, and our resources are contributing to it, and that's the only way to basically get the results which you want to have. If we are not following a plan, as Dr. Ahmed has said before, everybody comes with his own agenda, it's chaos. I'm doing a little bit here, I'm doing a little bit there, I'm doing a little bit there, but there's no symphony.
Okay, give me an example of the chaos.
You're putting me on the spot, so...
because again,